Hi guys. Anna, I think you might be muted.
That's so sad because it was such a good intro. Hi, everyone. Welcome. Good evening to our endocrinology road to final session this evening. Thanks so much for coming along. If you're here live and if you're not, hi, and from the past, I guess. My name's Anna. I'm an F1 at Manchester Royal Infirmary. And I've got with me
Tess, I'm an F1 at Conquest Hospital in Hastings.
we've got 10 lovely MCQs to go with you. Tess is going to start us off with the first five. And there's obviously like a very huge topic, so we've not hit every single thing we could possibly hit. And it's, to be honest, mostly, at least my questions, and I've looked through tests as well, mostly focusing on sort of management and that kind of things. We won't get into the nitty gritties of physiology and things, just because this would go on for 2 hours, and I'm sure no one wants to do that on their Thursday evening. So we'll try keep it as succinct as possible. So we're Thursday. Well, we were originally called Thursday 15. We're now MedTech teaching. We host a sort of teaching session every Thursday, usually about an hour long, where we go through different topics, and it's all on demand. So if you go through our Medal account, we've got loads of different videos on loads of different topics. I think most recently we had a gastro session on Tuesday, and the next one I think is Peds next Thursday as well. But you can always check out our Instagram account. I try to keep it updated as much as I can, or just follow us on Medal and you'll get the exact dates. So, is everyone ready to go? Can everyone hear us okay? Are we ready? Let's go. All right. Next slide then, please, Tess. So yeah, forgot to mention this is mapped to the UK MLA curriculum, so it should be quite comprehensive for what comes up in med school finals. And how it works is we'll give you a minute for each MCQ, and then at the end we'll go through each answer and sort of cover the topic surrounding the MCQ as well. Okay, are we ready to go? First question. Next question, please, Tess. I'm just going to read it out as well. A 65-year-old female presents to her GP complaining of weight gain, weakness, bruising, and low mood. She has past medical history of COPD, 20-pack year smoking history. She takes salbutamol, PRN. On examination, she has a round face, central obesity, bronze pigmentation of the armpit, and bruises on her arms and legs. Her BP is 160 over 137, and her blood sugar is 13. Given the most likely diagnosis, what investigation would be most useful for determining the underlying Next slide, please, Tess. 45-year-old male seen in the renal clinic for treatment-resistant hypertension. He's made positive lifestyle changes and is on optimal antihypertension medications. He's otherwise fit and well, although does complain of some regular headaches. Examination is unremarkable. The bloods are as follows. And what is a blood gas most likely to show? Next slide, please, Tess. 55-year-old female seen by her GP for frequent urination. She denies any dysuria or hematuria and reports that she's thirsty all the time. She has a past medical history of bipolar disorder. She takes lithium. Her bloods are as follows. Her urine dip is negative glucose in blood. In nephrogenic diabetes insipidus, what will the desmopressin stimulation test show? Next slide, please, Tess. 37-year-old female seen by her GP for anxiety. She describes frequent headaches, anxiety, palpitations, and sweating. Past medical histories of significant for neurofibromatosis type 1. On examination, she's found to have a tremor, heart rate of 114, and blood pressure 151/120. Bloods are as follows. And what is the first step in managing? Next slide, please, Tess. A 32-year-old female presents to her GP with a 6-month history of lethargy and weight gain. She's also noticed she's losing more hair in the shower than usual. Her vital signs are as follows. Heart rate 58, BP of 100/71, temperature of 36.7, and a respirator 20. Clinical examination reveals a loss of the outer third of the eyebrows and periorbital edema. Blood test results reveal a high TSH and low T3 and T4. Which antibody test is most likely to be positive in this patient? Next slide, please, Tess. 67-year-old male presents to A&E with nausea, vomiting, confusion. He has a past medical history of type 2 diabetes, hypertension, peripheral vascular disease. He initially was suffering from the flu, which seemed to resolve a week prior, but he has since deteriorated again. Vitals are as follows: heart rate of 102, BP of 99 over 64, temperature 36.4, and a rest rate of 28. An ABG is done, which shows the following. Which of the following medications is likely to have precipitated the above presentation? Next slide, please. An 82-year-old woman presents with confusion and disorientation. Labs reveal persistently low serum sodium, despite normal saline administration. Examination findings show that she's well perfused, has moist mucous membranes, non-raised JVP, and no signs of peripheral edema. Her medical history is significant for congestive heart failure, but no diuretic use. Which of the following suggests a diagnosis of SIDH? Next slide, please. 67-year-old male presents at A&E with nausea, vomiting, confusion, past medical history of type 2 diabetes, hypertension, peripheral vascular disease. He's initially suffering from the flu, which meant he was not able to get his repeat prescription from the pharmacy. Vitals are as follows: heart rate of 102, BP of 99 over 64, temp of 36.4, and a rest rate of 23. An ABG is done, which shows the following. Which statement is false about the fluid deficit and HHS? Next slide, please. 24-year-old woman presents to her GP after not having her period for the past 6 months. Past medical history of celiac disease and asthma. On further history taking, the patient reveals she's also been suffering with tiredness, irritability, and has lost 5 kilograms in the past 3 months unintentionally. Vitals are as follows: heart rate of 102 beats per minute, irregular, BP of 139 over 91, temp of 37, rest rate of 15, and oxygen sats of 100%. Which of the following would suggest this patient's symptoms are specifically due to the presence of anti-TSH or autoantibodies? And I think that's all the questions.
Absolutely. Okay, so we're going to now go through the questions, and it'd be amazing if you guys could put in the chat what answers you got. but don't worry at all about being right. That's the whole point of this talk. And then basically we're going to use each question as a little springboard to look at certain conditions within endocrinology. So for the first question, if people can just put in the chat, before we think about how we're going to manage this patient, what diagnosis do we think is the most likely here? So we've got someone that's been unwell for a few days, but has now come in sort of confused. They've got high heart rate, low blood pressure, low sugars, and if you look at their bloods, we've got high potassium, low sodium. Has anyone got any ideas what might be going on here? Okay, we'll move on. So what I'm trying to get at with this question is that the most sort of likely diagnosis, let me just, sorry, my computer's frozen, is an Addisonian crisis. So they've got tummy pain, they've got the low sodium, they've got a history of like sort of family history of autoimmune conditions, and they were a bit unwell in the preceding few days. So what answers did people put for managing this patient? Did they think a bit of insulin maybe? A bit of glucose if we've got the low blood sugar? Fluids, antibiotics, or hydrocortisone? Okay. So for this question, the most important sort of urgent thing is we need to give the patient hydrocortisone. That's going to reverse the Addisonian crisis and fix a lot of the other things. As part of treatment for Addisonian crisis, you absolutely do also give IV fluids. But if you look, this patient is reasonably stable. It's a young person, so that blood pressure is not super, super low. Their capillary refill is okay. So the first step of the algorithm is getting that IM or IV hydrocortisone in. Okay, I've sort of bolded all the things in the question that lead us to thinking it might be an Addisonian crisis, especially that low sodium and the tummy pain, the low sugars. That's all quite suggestive of Addisonian crisis. So if we just take a step back and just remember what the steps are in the adrenal axis. So in your hypothalamus, you have CRH, and that stimulates the production and release of ACTH, adrenocorticotropic hormone from the anterior pituitary, and that's going to cause the release of your cortisol, your stress hormone from the adrenal glands. And then the cortisol will give negative feedback back to the brain to reduce the pathway. So I find it's really helpful in endocrinology. If you remember what the hormone does, then you can think about what's going to happen if there's too much of it or not enough of it, because it will literally just be sort of a plus minus effect. So thinking about cortisol, it's your stress hormone, so it's going to increase your alertness, increase your blood sugar and your metabolism, getting you ready for doing things. It's going to suppress your immune system, and it also suppresses your osteoblast activity, which is important when we think about when we have too much of it, because that can cause osteoporosis. Aldosterone, we'll talk about the pathway that causes release of aldosterone in a bit, but it essentially causes you to keep all your sodium in, which keeps your water in and increases your blood pressure. In Addison's, which we're going to go on to, you don't have enough aldosterone, so you're losing all your sodium and you end up with the low sodium. Okay, the adrenal gland also produces sex hormone DHEA and also epinephrine, which causes your sympathetic response, which we'll talk about in a little bit. So if I just go on to the next slide. Adrenal insufficiency, that's what we were talking about in this question. That's a broad umbrella term for when you're not having enough of your steroid hormones, so your cortisol and your aldosterone. And when you have an insufficiency, you need to replace them. Addison's disease refers to primary adrenal insufficiency, where you've got a problem with the adrenal glands, usually autoimmune in nature. Secondary is when you have a problem with the pituitary, So you've not got enough ACTH being produced, maybe due to a tumour or radiotherapy. And then tertiary is just the next level up of the axis. Quite easy to remember. It's a problem with the hypothalamus. Usually it's long-term sort of oral steroids are causing negative feedback on your hypothalamus and you're not producing your CRH. Adrenal crisis or Addisonian crisis, which we had in the question, is your acute, severe adrenal insufficiency, and that's a life-threatening emergency, so it's really important that we know how to sort of treat that in the first instances. And like I say, the mainstay of treatment there is give them the hydrocortisone to replace it, and give them fluids, and then correct things like sugars and electrolytes as you go along. This is just a little bit of an overview of what symptoms people might have.
It could be me.
Can you hear me?
Someone in the chat mind just letting me know?
Have I frozen?
If Tess has disappeared for everyone else? Or is it just me? Let's see if I can get the slides up.
I don't know if anyone can hear me. I'm here. I've reloaded the web page. Can you hear/see me
You're
now?
back with me. I don't know if that was me or you, but Ting says that he could.
It could be me. It really could be me.
Good.
I'm using Safari and it didn't like that, but it didn't like Chrome either. Okay, I'm hoping everyone can hear and see both of us now. So I was just going through adrenal insufficiency. So if it happens over a longer amount of time, you don't get this crisis, then your symptoms can be broken down by the sort of hormones affected. So you might have, when you have low cortisol, you might have fatigue, weight loss, depression, because remember it's your stress hormone, it's making you alert, so it's going to do the opposite. When you have low aldosterone, you're going to have the low sodium, which is going to cause muscle weakness and cramps, dizziness, fainting. You might be craving salt. You might have tummy pain, nausea and vomiting. And then if it's an adrenal problem rather than pituitary or hypothalamic, you might have low DHEA as well, so you might have reduced libido. And in Addison's, because there's sort of no negative feedback to the brain, you're going to be producing lots of the higher hormones, including ACTH, and that causes bronze hyperpigmentation because it stimulates your melanocytes. Okay, but you wouldn't get that in a problem where there's not enough ACTH, for example. Addisonian crisis, like we said, you've got your reduced consciousness, your low blood pressure, low blood sugar, low sodium, and maybe high potassium. Investigations-wise, your routine bloods might have already sort of led you down this path. And then the first sort of quick screening test you can do is an early morning cortisol, although that's often actually falsely normal. The next tests you're going to do is your short synaptin test, where you basically use synthetic ACTH, which in a normal body should stimulate a doubling of your cortisol level. If it doesn't, then you've got some sort of adrenal insufficiency. It might be a primary insufficiency, so it's a problem with the adrenals because you're not responding to the ACTH, or your adrenals have atrophied in secondary insufficiency. So they've become so used to not producing stuff that they are no longer able to, essentially. And then you can look at your ACTH levels to distinguish between those two issues. A bit further down the line, you can also do autoantibodies to look at the autoimmune causes of the adrenal problem, and you might CT or MRI the glands or the pituitary to see if there's a problem. Replacement is just the main part of management is just replacement, and you're going to want to double your doses during illness because that replicates what the body would naturally do. And they're going to need a steroid card or some sort of ID so that healthcare professionals know not to stop their steroids. And we've already talked about the emergency protocol a little bit. Your adrenal crisis might be your first presentation of adrenal insufficiency, or it might be triggered by some sort of infection or trauma. So if you're suspecting it, but you don't know for sure, just start the treatment while you're waiting for the investigations. So if we go on to question 2, this is a patient complaining of weight gain, weakness, bruising, low mood, a bit of a smoking history, a bit of chest problems, and then on examination they've got rounding and bruising and that bronze pigmentation we've already talked about. So has anyone got any ideas of what the most likely diagnosis here is, and or what investigation they would find most useful for determining the underlying cause of that diagnosis? If I say the diagnosis is Cushing's syndrome, does anyone have any suggestions on how we might find out what's driving the Cushing syndrome? It's okay. It's been a long week for me too. So if we just go here, someone suggested Cushing disease. Very good. So it's quite a typical presentation of Cushing's disease. That sort of rounded face, central obesity. The bronze pigmentation again here is caused by high ACTH levels. And unlike the last case where there was low blood pressure and low blood sugar, we've got high everything because we've now got too much cortisol. Okay, we're going to go on to the tests on the next few slides, so I'll go over that a bit more. So Cushing syndrome is when you have too much cortisol and the other glucocorticoids, but that's the main one. And it's not quite the opposite of Addison's because you don't have aldosterone involvement, but a lot of the symptoms can be sort of equated to the opposite. Causes are a pituitary adenoma that's secreting ACTH. That would be Cushing's disease specifically. Steroid use, so oral steroids, etc. An adenoma on one of your adrenal glands, or one that we need to rule out is paraneoplastic syndrome. Very commonly, small cell lung cancers can be producing the ACTH. So if we identified Cushing syndrome in someone, we now need to figure out the cause. The symptoms that might sort of lead us to thinking it's Cushing syndrome can be visible, as seen in this diagram, including proximal muscle wasting, where they can't get up from a chair without using the hands. And on sort of examination, you might find that they've got hypertension, their sugars and stuff might suggest they've got diabetes, bloods might show dyslipidemia, they may have osteoporosis or even cardiac hypertrophy. And then psychologically, excess cortisol is going to potentially cause anxiety and depression, insomnia because they're staying alert, and rarely psychosis. So in terms of investigations, I found these really hard to remember. So I've tried to lay them out as clearly as I can. Basically, the biggest part of the investigations is dexamethasone suppression testing. If we think back to the pathway, steroids, so cortisol in the body or dexamethasone that we're giving exogenously, should suppress, give like negative feedback to the whole axis. So in a normal person, if you give them the dexamethasone, I think it's around 10 or 11 p.m. in the evening, the next morning at 9 a.m, a normal person would have low cortisol. Okay. But in any cause of Cushing syndrome, it's going to be high, or rather not suppressed, just normal. Okay? Then if we want to confirm that it's very likely Cushing syndrome, we can use the low dose 48-hour dexamethasone suppression test. So they take a very small dose of dexamethasone every 6 hours for 8 doses, starting at 9 a.m. on day 1 when you check the cortisol, and then you check again on day 3 after the last dose. Now, you're not going to suppress the cortisol production if it's being produced by the adrenal gland or by an ectopic ACTH, but you would be able to suppress a pituitary adenoma producing ACTH. So now we're left with, well, is it adrenal or is it ectopic? And that's when we do the high dose 48-hour test, because using a higher dose of dexamethasone can suppress the adrenal adenoma. Let me just check that I'm reading that right. I think I might have just said that wrong. The high dose 48-hour test will suppress cortisol if there's a pituitary adenoma. Yes, I was reading the table wrong. Apologies. It will suppress a pituitary adenoma, but it will not suppress an adrenal adenoma or ectopic ACTH. So the high dose test distinguishes if it's a pituitary adenoma or if it's one of the other causes. And then we can look at the ACTH level to see if it's an adrenal adenoma or something to do with the ACTH. Apologies if that was confusing. I can go over that again now that I've got my brain turned on. So you combine the dexamethasone suppression test with the ACTH levels to figure out where the problem is along the axis. You can also do the 24-hour urinary free cortisol. If you can't, for some reason, do a dexamethasone suppression test, but it doesn't sort of indicate the cause, just shows if you've got high levels of cortisol being produced in the body. Your bloods will show probably a high white cell count and low potassium if you've got an adrenal adenoma that's secreting excess aldosterone. Imaging that's useful: MRI brain to look at the pituitary, CT chest to check for cancer like small cell lung cancer, maybe CT abdo as well. Management is going to be removing the underlying cause, and then if that's an adrenalectomy, you might need lifelong steroid replacement. Another option is metirapone, which reduces production of cortisol by the adrenal glands. But usually it's just remove the cause and replace if needed. Okay. If everyone's happy with Cushing syndrome, I'm going to move on. So, question 3. Does anyone have a suggestion for what the diagnosis is before we look at the blood gas? So this is a young person with treatment-resistant hypertension, experiencing headaches, but examination otherwise unremarkable, no real past medical history, slightly low potassium and high sodium, and otherwise sort of normalish bloods. Okay. So this patient, from their presentation, is quite likely to have Codden syndrome, and in Codden syndrome, or more broadly hyperaldosteronism, you get a metabolic alkalosis. I'm going to talk about why. So aldosterone is part of the renin or renin-angiotensin-aldosterone system that responds to the blood pressure. If it's low, your kidneys are going to sense that in the juxtaglomerular cells in the afferent arterioles, and they're going to stimulate more production of renin. Okay, renin is going to stimulate the conversion of angiotensin in the liver to angiotensin 1, which will then go to the lungs and be converted by ACE into angiotensin 2. Angiotensin 2 is then going to work to increase your blood pressure by 3 methods: vasoconstriction, cardiac remodeling, so more to allow more pumping, and aldosterone release. And we talked a bit earlier about what aldosterone does. Does anyone remember what it does in the kidneys? Specifically around sort of sodium and water. Causes water retention and sodium, absolutely. Very good. So if we go to this next slide. So the main way it's going to affect blood pressure is by reabsorbing sodium in the distal tubules of the kidneys, which means you will then also reabsorb more water and you're more filled, and then you have a higher blood pressure. So that contributes to this sort of pathway here by filling you more. So you've got angiotensin 2 is going to cause squeezing of your vessels, pumping of the heart, and retention of water by aldosterone. You then get the higher blood pressure, and that gives negative feedback to renin. So it can sort of balance out. As well as that, aldosterone is going to increase potassium secretion in the distal tubule, and also hydrogen secretion from the collecting ducts, which is going to affect your pH. Hyperaldosteronism, when you have high levels, is when you have high levels of aldosterone. It actually accounts for 5 to 10% of hypertension. It's the most common cause of secondary hypertension. And Conn's syndrome specifically is when you have hyperaldosteronism due to an adrenal adenoma. The main presenting feature of hyperaldosteronism is hypertension. You often have no other symptoms or very sort of vague, non-specific symptoms like headache, weakness, fatigue. Your bloods are going to show a high sodium and a low or normal potassium sometimes. And you're going to get a metabolic alkalosis because you're secreting all of your hydrogen. So that was the answer to question 3 in this case. As it's the most common cause of secondary hypertension, you need to test for it in young patients with hypertension if you've got a patient where treatment's not working, or if the patient also has low potassium, because that can be sort of a clue for you. Conn's syndrome is sort of one key cause. Can anyone name any other causes of hyperaldosteronism? Anna, I'm going to make you start answering the questions. Don't worry, I'm just joking.
Oh no, okay. Please, the reason I didn't cover this one.
These are hard, to be fair. I didn't even know all of this for finals. Like, you keep learning when you get into F1. So primary causes, where you've got adrenal overactivity, you're producing too much aldosterone. Most commonly would be a bilateral adrenal hyperplasia. You can also get adrenal adenoma, Conn's syndrome, and more rarely familial hyperaldosteronism. Secondary hyperaldosteronism is caused by excess renin production, which might be due to renal artery stenosis, heart failure, or liver problems. Basically, you have a disproportionately low blood pressure in the kidneys, so you're producing lots of renin, and that's producing lots of aldosterone, but it's not really helping the renal artery stenosis at all. You're going to investigate by looking at the aldosterone to renin ratio, the ARR. In primary, you'll have high aldosterone and low renin, because there's negative feedback on the renin, but in secondary, they're both high, because there's no feedback going on. The renin is independent. You then might do a CT or MRI to look for adrenal tumours or hyperplasia, a renal artery Doppler or a CT angiogram or MRI angiogram to look for stenosis. And you can also do adrenal vein sampling to see if one gland is producing more than the other. But then essentially, once you've figured out the underlying cause, the treatment of hyperaldosteronism is to treat the underlying cause. So remove the surgery, open up the stenosis, etc. You can also give aldosterone antagonists, something like a eplerenone or spironolactone, and they should counteract. the aldosterone. Okay. Please feel free to put any questions you have in the chat as we go along, or if I haven't explained something well, I can try and say it again in a different way. But we'll move on to question 4 for now. So this is a patient with frequent urination, but no other urinary symptoms and thirsty all the time. Her only medication is lithium, and her bloods, you can see for yourselves. She's a little bit salty in her blood and has very dilute urine. And thinking about differentials, the HbA1c and the urine dip don't suggest sort of diabetes as the cause of your polyuria, polydipsia, diabetes mellitus that is, and they also don't suggest like a urinary tract infection. So this is a case of diabetes insipidus, and then the question has decided to go for nephrogenic diabetes insipidus, but there's also something called cranial diabetes insipidus, which is probably what this patient would be more likely to have with their lithium. So has anyone got any idea what a desmopressin stimulation test is and what it might show in nephrogenic diabetes insipidus? I think I'll move on just on the interest of time. So we're going to go through why, but basically they're going to have low urine osmolality, so very dilute urine after desmopressin has been administered. I'm going to look at why in a second. So again, taking a step back, just reminding ourselves of what the hormones do so that we can understand where the problem is. ADH, antidiuretic hormone, is produced in the hypothalamus, secreted by the posterior pituitary gland, and it causes water reabsorption, so stop P, don't stop the water going, water reabsorption from the collecting ducts in the kidneys. I think Anna's going to talk about SIDH a little bit later, but that's basically when you have too much ADH, so you're absorbing too much water. And we're going to talk about diabetes insipidus now, where you haven't got enough ADH, so you're not absorbing your water, you're peeing a lot. So you're going to have very dilute urine and potentially concentrated blood. And if you've got concentrated blood, you're going to want to dilute that, so you're going to feel thirsty. Okay. A problem with ADH can be pinned down to two places. You can either not be producing enough in the brain, so that's cranial diabetes insipidus, or your kidneys might not be responding to the ADH, nephrogenic diabetes insipidus. Okay. Problems in the brain can be anything, can be idiopathic or brain tumour, infection, surgery, genetic mutations, Wolfram syndrome, and then nephrogenic wise could be caused by, so medications. In my notes I've written here lithium, so that would actually be nephrogenic. I was wrong, apologies. Hypercalcemia, hyperkalemia, and any kidney disease like polycystic kidney disease can cause nephrogenic diabetes insipidus.
I wonder if anyone remembers like the other name for ADH at all. This very confusingly, because in medicine we just can't have enough names for things.
Absolutely.
I don't know. I kind of prefer this name actually for ADH, vasopressin, which is useful because Tess has just mentioned that vasopressin is what we use to test for diabetes insipidus. So it's just something to link in your brain. They're related.
Absolutely. It's very helpful to know like various different names, because sometimes the names tell you exactly what it does. There's another condition that I haven't put on here that might cause polydipsia and polyuria. That's called primary polydipsia, where you've got excessive water consumption, but there's nothing wrong with your ADH system. So you're going to have a euvolemic hyponatremia, low sodium, but you're also going to have dilute urine. So everything's diluted because you're just drinking lots and peeing lots. Okay. So diabetes insipidus, specifically, it's going to present with polyuria, polydipsia, you're going to feel dehydrated, and you might have postural hypertension because you're peeing so much of your water out. Your serum osmolality will be high or normal, potentially, if you're drinking enough to sort of maintain it, and your urine osmolality will low, dilute. If you decide to do a 24-hour urine collection, they're going to produce more than 3 litres over 24 hours. But the diagnostic test is going to be your desmopressin stimulation test, which is also known as the water deprivation test. So you basically deprive the patient of fluids for up to 8 hours and then measure their urine osmolality. You and I would then have very concentrated urine, but in diabetes insipidus, they're still going to have the dilute urine that they were having before. It's not going to respond to water deprivation. So if you've ruled out diabetes insipidus because they've got high urine osmolality, great. If not, you're going to give your desmopressin. Desmopressin, pretty sure it's just a synthetic version of ADH. Yes, synthetic ADH. And you're going to then measure the urine osmolality over the next 2 to 4 hours to see if there's a response. In cranial diabetes insipidus, it's just that you're not making enough. So if you give fake ADH, your body is going to respond and you're going to start concentrating your urine by reabsorbing the water. In nephrogenic diabetes insipidus, your kidneys aren't responding to the ADH, so even if you give synthetic ADH, your kidneys won't respond, so your urine osmolality will remain low. Okay, which is, I think, what we had in the question. Management-wise, as with all the conditions we've gone through so far, you're going to try to address the underlying cause if you can. So if it's caused by medication, stop that. A tumour, chop it out. Conservative management can work in mild cases. And then in cranial diabetes insipidus, you can give desmopressin to replace the ADH levels. Nephrogenic diabetes insipidus is a bit harder to treat. The endocrinologist will lead this, but they might suggest high water intake, high dose desmopressin prescription, thiazide diuretics, and things like NSAIDs, but it's a lot harder to treat. Okay, we're on my last question, then I'll hand over to Anna. So, question 5. This is an anxious lady having headaches, anxiety, palpitations, sweating. She has something called neurofibromatosis type 1, a tremor, high heart rate, and high blood pressure. Blood's actually kind of normal apart from the plasma metanephrine. What do people think might be going on here? And or how would they try and treat this? Excellent. Someone suggested pheochromocytoma, which is spot on diagnosis. How would you manage a pheochromocytoma? I'm glad no one said like thyroid, because that was sort of my trick differential that people might jump on it. So management of pheochromocytoma, the first sort of step is going to be an alpha blocker like doxazosin. I've highlighted the sort of key parts of this question that are leading us to that diagnosis, but we're going to talk about the presentation now. So pheochromocytoma is an adrenaline-secreting adrenal tumour, usually non-cancerous, and 10% of them are cancerous and 10% are also bilateral. The chromatin cells of the adrenal gland, they produce excess adrenaline, which is released in bursts and gives us intermittent symptoms of anxiety, sweating, headache, tremor, palpitations, hypertension, tachycardia, basically everything that you want the adrenaline to do in a sort of a stress situation where you need to fight a bear or a man in the woods, but it's doing this uncontrolled in bursts. 30 to 40% are genetic. I've put them sort of the common causes here, and in our question it was a patient with neurofibromatosis. I can't speak today. Neurofibromatosis type 1. Okay. Adrenaline is a catecholamine. You also got sort of other names for it, noradrenaline or epinephrine and norepinephrine, if you're American. And it's basically a fight or flight. So in pheochromocytoma, you can look at the plasma-free metanephrines, which is the sort of metabolic breakdown of your adrenaline. And they have a longer half-life because the actual adrenaline is only going to be in your blood for like a few minutes. So it's not going to be reliable if you test that at a random point in time. But your metanephrine is going to stay around and be helpful to measure. And you can also measure 24-hour urine catecholamines. So catecholamine is the umbrella term for adrenaline and noradrenaline. And you can capture how much is being released in the urine to sort of measure how much might be being produced in the body. CT and MRI can help you visualize the physical pheochromocytoma tumour, and you can do genetic testing if you want to think about a genetic cause. Management, like I said, is alpha blockers first. The next step is then beta blockers, and then surgical removal. Catecholamines work on both alpha and beta receptors. Their effect on alpha receptors is that they cause vasoconstriction, whereas beta receptors cause vasodilation. So when you've got the effects on both receptors, it can kind of even out. But if you use beta blockers before you've given someone an alpha blocker in pheochromocytoma, because you want to reduce the heart rate, for example, then the unopposed alpha-mediated vasoconstriction can lead to a hypertensive crisis or pulmonary edema. So you always need to make sure you've blockaded the alpha receptors first with doxazosin or phenoxybenzamine. Then you can start giving them beta blockers. That's safe. And the reason we do all of this before the surgical removal is to make sort of anesthesia and surgery safer, because you're going to have a fight or flight response to having surgery, and you don't want that to be uncontrolled. So we try and control all their symptoms medically first, and then chop out the tumour when it's safe. But like I say, it's usually a non-cancerous producing tumour. Brilliant. If anyone's got any questions about the topics I've covered, hit me up in the chat, but I'm going to hand over to Anna now for questions 6 to 10.
All right, let's go then. Question 6. A 32-year-old female presents to her GP with a 6-month history in lethargy and weight gain. She's also noted that she's losing more hair in the shower than usual. Her vital signs are as follows. Very quickly before I do this, I'll send out the feedback form in case anyone needs to drop out now. It'd be really, really useful for you to fill that out. It really helps me and Tess and us as an organisation to see how we could better improve our sessions. Otherwise, if you've got a few more minutes to hang on for the rest of the session, that would be really great, and we'll continue. Otherwise, it will be on demand, like I've said before, so don't worry if you can't stay to the end of the session. But please do provide us feedback if you've got a spare couple minutes. So we have so kind of a little bit bradycardic, I would say, 58, not quite 58 beats per minute. Blood pressure a touch low, temp normal, rest rate just about right. We've got some weight gain and lethargy, loss of the outer third of the eyebrows. TSH is high, T3 and T4 are low. Do we know what kind of diagnosis I'm trying to get at here? Anyone in the chat? If anyone's still around. So I'm trying to get at, we've got someone in the chat. Hypothyroidism, amazing. Thank you so much. So does anyone know which antibody test is most likely to be positive in this patient? I know this is something that really got me confused in med student, because there's so many different types, which is why I really wanted to just go over it. In the case of hypothyroidism in the West, the most common cause is Hashimoto's. And in that case, next slide, please. The answer would be antithyroid peroxidase, if it comes up on the next slide. Don't know if it's just my internet or not. Yeah, perfect. Next slide again. So we'll just quickly go over to our favorite hypothalamic pituitary thyroid axis. So the hypothalamus, no worries, Tess. The hypothalamus releases thyrotropin releasing hormone, which stimulates the anterior pituitary gland to release thyroid stimulating hormone, which then stimulates the thyroid gland to produce T3 and T4, which is they're very important hormones in the regulation of your metabolism. T4 particularly is the active form. T4 is the pro-hormone, but we've got 14 times more T4 than T3 in our body. And T3 increases the basal metabolic rate, it affects protein synthesis, it helps regulate long bone growth, neural maturation, and it increases the body sensitivity to catecholamines. And if we just put that in context of, well, what does it mean when our thyroid hormones are high or low, we can go to the next slide. So we can get an hypothyroidism, which is what we were seeing with our lady in this question, some weight gain, fatigue, bradycardia, cold intolerance, constipation, depression, mental fog, impaired memory, muscle weakness, dry, coarse hair and skin, which makes sense if we slow down our metabolism all the way down. This is what we will inevitably get. And if we speed everything up, increase our metabolism, we'd get some weight loss, we'd be paradoxically either fatigued or hyperexcitable. I mean, you can see how that would be if we're constantly feeling like we're on the go, if we've got palpitations, tachycardia, that can tire someone out. Otherwise, or it could make us hyperexcitable and would be associated with mood changes like anxiety, irritability, insomnia, mood swings. We could suffer with some heat intolerance, diarrhea, diaphoresis, and I sort of hinted to it earlier, where I suggest that the most common cause of hypothyroidism in the West is Hashimoto's, and the most common cause of hypothyroidism in the West is Graves' disease, whereas in the developing world it's an iodine deficiency. Next slide, please. So this, it takes a while to sort of get your head around this diagram, but once you get it, feels good. We've got which different antibodies are related to which disease. So there's obviously an overlap, which is annoying, but basically we've got thyroid peroxidase antibody in Hashimoto's thyroiditis, which is present in 90% of people who have Hashimoto's and 75% of Graves' disease. And then we have our TSH receptor stimulating antibodies, which are mostly present in Graves' disease, 90% to 100%. And then our thyroglobulin antibodies on the top right, which we can see 70% in Hashimoto's and 30% in Graves. And sometimes you can see it in thyroid cancer as well. And Tess kind of alluded to it in her when she was talking about primary hyperaldosteronism and secondary hyperaldosteronism. It can sort of be applied to any endocrine disorder, really. So any primary endocrine disorder is going to affect the gland that produces the hormone that we're talking about. So in that case, primary hyperthyroidism would be affecting the thyroid gland. Secondary hyperthyroidism, does anyone know what that would be affecting? Say hypothyroidism. Does anyone remember? It would be affecting the anterior pituitary, and then tertiary hypothyroidism would be affecting the hypothalamus. You just take a step back and a step back and a step back. Great. Next slide, please. Oh yeah, just quickly. We've got hypothyroidism. Some of the causes that I mentioned include Hashimoto's, which is the most common in the UK, which is an autoimmune disease, and it's got sort of various mechanisms that cause its pathophysiology, so I won't get into it too much. It's important to note that many diseases that result in hypothyroidism have an acute hyperthyroid phase, so that does include Hashimoto's. So at the beginning they might have all of these effects of hyperthyroidism, anxiety, irritability, high heart rate, palpitations, and then after the acute phase it will then result in the hypothyroid phase. So that's true of Hashimoto's, not all the time, in some cases, and also true in postpartum thyroiditis and also subacute thyroiditis, which they're all diseases that result in hyperthyroidism. And in terms of hyperthyroidism, we've got Graves' disease, which is the most common cause of thyrotoxicosis or a thyroid storm. And also toxic multinodular goiter, which is when we've got independent sort of nodules in our thyroid that are releasing T3 and T4 so willy-nilly, regardless of what the hypothalamus and the pituitary gland are saying, into the bloodstream, causing a hyperthyroidism. And the drug amiodarone as well can cause hyperthyroidism. And therefore the treatment sort of depends on the cause. If it's hypothyroidism, all you really need to do is replace the thyroid that's not being made. Does anyone know which drug we use to treat hypothyroidism at all? Levothyroxine. And in the case of hyperthyroidism, oh yeah, perfect, someone's got it in the chat. Hyperthyroidism, we use a certain drug to control the symptoms of palpitations, which is usually propranolol, which is our beta blocker. Or we can use, to specifically address the excess production of thyroid hormones, we use carbimazole, and that stops thyroid peroxidase from iodinating tyrosine residues on thyroglobulin, which is used to produce T3 and T4. The other thing we can use is radioiodine therapy, which is used in things like thyroid cancer and toxic multinodular goiter to essentially render these nodules from making the T3 and T4, and in extreme cases you would need surgery. But obviously once you have surgery to remove your thyroid gland, you need to then replace it exogenously with levothyroxine for the rest of your life. So we just tend to go from conservative to the last resort would be surgery. Great, next slide please. So we've got a 67-year-old male. I've put two questions in that seem quite similar, but they're getting at different things. So we'll see if we can sort of pull it out from this question. So we've got a 67-year-old male with type 2 diabetes who had the flu a few weeks ago, but he's gotten worse again. And I was asking which of the following medications is likely to precipitate the above presentation. So what can we get from this? So he's got a low pH, meaning he's acidotic. He's got a low bicarb. He's got a low potassium as well. And the sodium's okay for now. I'm really sorry, I forgot to put the reference ranges, so I feel like this is a bit mean of a question, but Tess has put them up before, so maybe you noted them down or something. So we've got a metabolic acidosis. So does anyone know what this gentleman might be suffering from at all in the chat? So it seems like a diabetic ketoacidosis, doesn't it? Which is unusual because he's got a type 2 diabetes and his glucose is normal. So we might call it a euglycemic diabetic ketoacidosis. And the drug that's most commonly associated with euglycemic ketoacidosis is dapagliflozin. Next slide, please. There we go, dapagliflozin. Next slide again. So I'll just quickly talk about the diagnosis of type 2 diabetes. So type 2 diabetes can be diagnosed in one of two ways. The first way is using HbA1c, which shows us sort of roughly the amount of glucose in our bodies, and it's a rough guide of 3 to 4 months, because that's the lifespan of a red blood cell. So to have a diagnosis of diabetes, it needs to be over 48. Or we can do a fasting glucose or a random glucose test as well. And if the fasting glucose is above 7 or the random glucose is above 11.1, we can say that this person has diabetes, but that's only if the patient is symptomatic. If they're asymptomatic, you would need to repeat the test 2 times to confirm a diagnosis of diabetes. Now, NICE wants you to know, and I feel like this is quite high yield, which conditions you mustn't use HbA1c in. And that includes children and young people less than 18 years of age, pregnant women, or women who are 2 months postpartum. And I know that there's anyone with sort of any diseases, hemoglobinopathies affecting their hemoglobin and therefore their HbA1c, you wouldn't be able to use the HbA1c for them either to diagnose diabetes. Next slide, please. So we've got some different targets depending on the therapy the patient is on. So if we're thinking lifestyle or lifestyle metformin alone, we're trying to aim for a HbA1c of 48 or below. And if it's lifestyle and any drug that can cause hypoglycemia, and I'll get to which drugs can cause hypoglycemia, we're aiming for a HbA1c of 53. And that's because we don't want too tight of a control with someone who's got any drugs that can cause hypoglycemia, because it could be indicating that they've got excess hypos, which in the elderly population, which is what type 2 diabetes usually affects, can be quite dangerous, as you can imagine, because symptoms of hypoglycemia can result in coma, and therefore falls, and can even be fatal. So we really want to minimize the amount of hypos that we're having. That's why we tend to shoot for a bit higher target for people who are on any drugs that cause hypoglycemia. Weirdly enough, this doesn't apply to people who have type 1 diabetes, and we're still aiming for 48 millimoles per mole, which is unusual, I thought, because they're taking insulin, which is definitely a drug that causes hypoglycemia. But that's what NICE suggests, so that's what we're going to stick with. Next slide, please. So in terms of how we're treating type 2 diabetes, our first line is always going to be metformin. Usually in practice, I've seen people prescribing metformin modified release instead of immediate release, and that's just because the gastrointestinal side effects are better tolerated with the modified release. And in people who've got either chronic heart failure or any established cardiovascular disease, you want to really be adding an SGLT2 inhibitor as well. And that's because they're proven to help in terms of improving the mortality of people with heart failure and diabetes. And if that's not achieving our targets, then we need to move on to our secondary drugs, which are including our SGLT2s if they're not already taking it, DPP4 inhibitors, pioglitazone, and sulfonylureas. But you really need to be checking the interactions as well. And you can add on, for example, if you started them on a DPP4 inhibitor and it's still not working, you can then add a sulfonylurea, and so on and so forth. And if all of that's not working, we can consider GLP-1 agonist, which is our semaglutides or glutides or Ozempic. That's usually if there's other risk factors involved, because they're so short in supply on the NHS right now. So that includes BMI of over 35, which needs to be just for ethnic group, and that's because they're shown to obviously help with weight loss. or we can then consider our insulin therapy. I've not really gotten into too much detail about insulin therapy in this because it's already 8:15. So next slide, please. So I feel like, oh, it's just cut off there. That's quite sad. That's fine. You know what? I'll upload this to our Instagram because it's a very useful table that sort of summarizes what each different drug does. There, the ways to remember it according to the suffix, their mechanism, and important things to know about each drug, which I won't bore you by reciting off the slide. Again, it's on demand, so you can either come back and watch this video, or again, just look at our Instagram and I'll upload it there. Next slide, please. And this is just a diagram that I found on the internet explaining how SGLT2 inhibitors, your dapagliflozins, tetracanagliflozins, can cause a euglycemic decay, which is unusual to see in someone with type 2 diabetes. And again, I won't bore you with going through all of it, but it's there on the slide if you would like to pause and read it. Next slide, please. Perfect. So again, DKA management, which you don't want to go into too much detail about because it could be here for hours, but the most important thing is fluid. People in DK are very, very volume depleted, so we need to do some aggressive fluid replacement, and this is sort of based on each trust. They've got their own guidelines. NICE doesn't have specific guidelines on this, and obviously the next most important thing is insulin therapy. So everyone needs to be started on a fixed rate insulin infusion, and that's usually 0.1 units per kilogram per hour. And when the glucose starts dropping below 14, which is less relevant in a euglycemic ketoacidosis, you need to add in your 10% glucose to prevent any hypos as the insulin keeps running. Important thing to note is a lot of these fluids that we're giving will have added potassium in them, and that's because insulin causes a decrease in potassium levels as well. Next slide, please. Great. Question 8. An 82-year-old woman presents with confusion and disorientation. Labs reveal persistently low serum sodium despite normal saline administration. And what do we think? I've tried to sort of get onto the volume status of this patient. So would anyone want to suggest whether they think this patient is hypovolemic, euvolemic, or hypervolemic based on the examination findings? So they're well perfused, moist mucous membranes, JVP's okay, no signs of peripheral edema. Yeah, they seem euvolemic, don't they? Despite the history of congestive heart failure, they've not got any diuretic use, suggesting they don't have a particular problem with peripheral edema. And that might be because they're suffering from, for example, left-sided heart failure, which is less likely to cause peripheral edema compared to right-sided heart failure. Which of the following suggests a diagnosis of SIDH? Does anyone know? Anyone want to hazard a guess in the chat? It's okay if not. I wouldn't have any idea if you asked me weeks before my finals. That's fine. Next slide. So urine osmolality of 400 milliosmoles per kilogram. Great. Next slide. Hyponatremia, one exciting topic. You could definitely tell I'm absolutely so interested in this. So our symptoms of hyponatremia, we could be tired, we could suffer with nausea and vomiting, headache, confusion, muscle spasms, dark urine, and then extreme cases, if it's a very, very low, we can have convulsions or seizures, and even behavioral changes. There's many potential causes, and I'll try and go through a systematic way of approaching the hyponatremic patient, but Tess has kindly listed out a couple of reasons for hyponatremia, including dehydration, heart, liver, kidney disease, a high water intake, which Tess alluded to earlier when she was talking about diabetes insipidus, So let's see, how are we going to address a patient with hyponatremia? Next slide, please. So we're going to try to take it in 3 different steps. So the first thing we really want to assess is a plasma osmolality. See how many solutes we've got in our blood, what's going on. Do we have a hypotonic hyponatremia, eutonic hyponatremia, or hypertonic hyponatremia? We're going to look at the volume status as well, which is why I included it in the question. Very important for any patient that you've got with hyponatremia. It's always important to do a fluid assessment and then fluid balance assessment. And then finally, we can use the urine osmolality to give us a final clue as to what's going on. So, next slide. Plasma osmolality. So like I said, we can either be hypotonic, eutonic, or hypertonic. Next slide. And if we're eutonic or hypertonic, this isn't really matching up, is it, with our hyponatremia? Because if we've got hyponatremia, we would expect to be hypotonic because we've not got that solute in our bloodstream. So in the cases where we've got a hypertonic or eutonic hyponatremia, we need to think, is there another solute that's causing us to be hypertonic, i.e. hyperglycemia, which would cause hyponatremia? Because if you can imagine, we've got loads of sugar in our blood, our body will try and reabsorb water and therefore dilute the sodium that's already in our blood. We may not actually have a low sodium, but it appears like we've got a low sodium simply just because of the balances of solutes in our blood. Or we've got a pseudo hyponatremia, meaning we might have low fats, which is causing us to appear again like we've got low sodium when we don't. A true hyponatremia would have to be a hypertonic hyponatremia. So we go on to our next step, which would be assessing volume status. And again, I went through, we can be hypervolemic, euvolemic, or hypovolemic. And that would mean, next slide. If we're hypervolemic and hyponatremic, so we've got our peripheral edema, we've got peripheral pitting edema, we've got crackles on the chest, we've got raised JVP, we could have anosarca if it's particularly bad. That's due to renal failure, cardiac failure, nephrotic syndrome, and cirrhosis. If we had a hypovolemic hyponatremia, then we need to think about, where is this? Where is it going? Are we vomiting it all up? Are we maybe pooping it all out? Is it because of an Addison's? Are we wasting away in our urine? Or dermal losses such as burns? Is it all third spacing? And then if we're euvolemic, we can go on to our next step, which is checking our urinary sodium. And we can either be over 100, which is a high urinary osmolality, so very concentrated urine, or very dilute urine under 100 milliosmoles per kilogram. So let's just think about it. We've got a hyponatremia, we're euvolemic, we've got either concentrated urine or really dilute urine. And so next slide. If you've got really dilute urine, we're thinking about water intoxication or inappropriate IV fluid therapy. And that includes our primary polydipsia, which Tess mentioned earlier, which can be, the most common causes that we think about in our textbooks are psychogenic primary polydipsia, which can be seen in conditions like schizophrenia, which they just keep drinking loads of water. Or beer-potomania, which again, when you're just out and you just keep drinking loads of water. And then we've got our beautiful, wonderful SIDH if we've got a euvolemic hyponatremia and we've got very concentrated urine SIDH, which was what the question was alluding to. So next slide, please. What is SIDH? Because as I said, I didn't really understand it ever in med school, so I'm glad we're going over it together. It's a syndrome of inappropriate antidiuretic hormone secretion, which is very useful. So let's elaborate. Next slide, please. So syndrome of inappropriate antidiuretic hormones. So we've got too much ADH, or like I said before, I prefer vasopressin as a name. I just feel like that helps me visualize what ADH is actually doing instead of this double negative or whatever. So what is ADH? The posterior pituitary releases ADH in response to low circulating volume of water. And it acts on the kidneys to increase aquaporin 2 receptors in the distal convoluted tubule and the collecting duct. And that means that we've got low circulating volume and the kidneys are trying to reabsorb the water back from the urine into our blood, so we increase our circulating volume, which results in more water in the blood, but then more concentrated urine, as we can imagine, because we're taking it out of the urine and putting it into the blood. Next slide, please. I just thought, like, we'll probably need to pepper in some fun into this, the nitty-gritty of endocrine. So there we go. Next slide. Sorry. Next slide. So SIDH involves continuous inappropriate ADH release, which is not affected by normal physiological feedback. So it's just going to continue to release ADH. So the kidneys are reabsorbing more and more and more water, making our blood effectively more dilute and our urine really, really concentrated. So we just keep excreting that sodium out. And then all the excess, you would think then, where is all of this fluid going? Why aren't we getting any peripheral edema? Our bodies are just able to deal with it at the level that the proportion to the ADH is distributed evenly across all compartments of our body. And it specifically dilutes our blood electrolytes, including sodium, causing hyponatremia. And therefore, that's why we get the results that we get in SIDH. Next slide. There's many different causes. The mainstay of treatment is fluid restriction. And there's many different causes that I put up there. One of the most important causes, I think, that you'll see day to day as a doctor, especially foundation doctor, is medications such as SSRIs, antipsychotics, anticonvulsants, a million different reasons. But there we go. Next slide, please. Question 9. So we've got a 67-year-old male with nausea, vomiting, confusion with type 2 diabetes. This is the one that was similar to the one that we've already been through, who had the flu, and that meant he didn't get any of his repeat prescription from the pharmacy. So whatever drugs he was taking for his type 2 diabetes mellitus, he's not been taking, and he's been recently ill as well, which is important to note. He's tachycardic, he's a bit hypertensive, his respite rate's a bit high, and he's confused, which is important as well. This is quite an unwell man, which might prompt us to do an ABG, which reveals a metabolic alkalosis, a very, very stunningly high glucose of 36, and a very high sodium of 160. So we're talking about HHS, or hypoglycemic hyperosmolar states, which is a diabetic emergency seen in type 2 diabetes. And the question is getting at which ones of these are not true about HHS. Next slide. Which is the first one. In fact, our losses of fluid in HHS are much, much greater, as you can imagine, as we're trying to, we're just so dehydrated from the high sugar content in our blood. Next slide, please. So it's as I said, diabetic emergency, and this is very important, has significant mortality. I think something about 5 to 10% of people who have HHS unfortunately go on to pass away due to this condition. And in its earlier stages, we're getting the urinary frequency, thirst, nausea, severe dehydration, and then it can lead to confusion and ultimately can lead to coma or even death. So there's no strict hard and fast rules as to how you diagnose HHS, but you can usually tell someone might have it if they've got blood glucose of over 30 or a really high raised serum osmolarity of over 320. And we can roughly calculate the serum osmolarity by 2 times sodium plus glucose plus urea, and if it's over 320, we're likely dealing with an HHS on our hands. And there's the nice guidelines as well about what suggests a diagnosis of HHS. Next slide, please. So yeah, like I said, in a person weighing 100 kilograms, we're looking at 10 to 22 litres of fluid losses in HHS. So we need to be doing some aggressive fluid resuscitation. And what's different from DKA versus HHS is that most of your glucose reduction is going to be from that aggressive fluid replacement, and that's what's going to lower our blood glucose instead of the insulin. Which is typically not needed in people with HHS, only if their blood glucose, if they're not responding enough to the fluid replacement, can we consider further insulin therapy. But to be honest, this is kind of, we're approaching past the level you need to know for your med school finals. The important thing for HHS is you really need to be involving a senior, because it's a very complicated condition that needs sort of endocrinologist input, or at least input from a acute medic consultant. So we need to consider prophylactic low molecular weight heparin in most people. I mean, most people in hospital, all inpatients usually get a prophylactic low molecular weight heparin, but in people with HHS, there's a very high risk of clots, including stroke and myocardial infarction, which is why it carries such a high risk of mortality. And other things we need to consider is not dropping the sodium too much. So yes, the sodium is blindingly high at 160, but does anyone know what happens if we correct sodium too quickly? Does anyone know what condition that results in? Usually in cerebral edema, and that's because we're correcting the sodium, so then the water moves into the brain cells, and that increases your intracranial pressure, and that can result in seizures and ultimately herniation and brainstem death as it herniates through the brainstem. So that's one thing we need to consider, and that's why we usually use 0.9% sodium chloride. So that's what we call eutonic sort of sodium chloride, and we can consider using 0.045 or hypotonic sodium chloride after that if the patient isn't shocked and we're not seeing much improvement with sodium chloride 0.9%. Great, and the form glucose shouldn't be more than 5 millimoles per litre per hour, and that's for a similar reason, to minimise the risk of neurological complications. Cool. And last question. Oh yeah, some precipitating factors before we move on of DKA and HHS. Infection, non-adherence with diabetic treatment, which we got from the questions stem actually. New onset diabetes, so people who don't know they've got diabetes, or people newly diagnosed with diabetes. Great. Next slide, please. Question 10, this one isn't long at all. We've got a 24-year-old woman with past medical history of celiac disease and asthma, so she's got a history of autoimmune disease, suffering from amenorrhea. She's also suffering with tiredness, irritability, and has lost 5 kilograms in the past 3 months. Does anyone know what we're trying to get at here? Which disease might she have, considering the antibodies? Graves' disease. There's some symptoms in Graves' disease that are specifically associated with Graves' disease and not other causes of hyperthyroidism. That's specifically linked to the presence of anti-TSHR autoantibodies. So in this case, next slide, it's B, swelling or clubbing of the fingers, and it's also known as thyroid acropathy. Next slide, please. So these are specific features of Graves' disease, the ophthalmopathy, the specific eye signs that are associated with Graves' disease. We can also get a non-pathedema of the tibias, pretibial myxedema, or thyroid acropathy, which is a combination of clubbing and swelling of fingers and also new periosteal bone formation, so very chubby, swollen fingers. Great. Thank you so much for listening. So topics that we didn't mention today, as you know, it's 8:30, so we always run late, but there's a lot to get through. Hyperparathyroidism, which we covered actually in our renal talk that tested that for us. Acromegaly and sex hormones as well, useful to cover as part of the UK MLA curriculum. Thanks so much, everyone, for joining us this evening. And thanks so much for all your feedback. It'd be really helpful, like I said, if you could fill the form out, let us know what we could improve on, what you would like to see from us next, any suggestions. And I really hope that was useful for all of you. Thanks so much for hanging out with us and spending your Thursday evening revising. Thanks, everyone. Bye.